TNM AJC 9th edition has changed N2 disease to different categories. N2A is a single mets in mediastinum lymph nodes, versus N2B is multiple lymph node involvement in the mediastinum or subcrinum. As a result of these changes, some of the previously higher stage lung cancer downstage to stage 2B, such as T1N2A, used to be stage 3A, now is stage 2B. T1N2B stays as a stage 3A as an 8th edition. For the T3 and T2N2A still stayed at stage 3A. However, if they do have N2B disease, it upstage to stage 3B. For T3 and T4 with N3 disease, also it upstage from stage 3B to stage 3C. So that may change the treatment because, for example, a stage 2B or T1N1A, we may consider preoperative chemoradiation or chemotherapy, immunotherapy, rather than just doing the surgery. And if the patient has multiple lymph node involvement in mediastinum, they may exclude it from preoperative chemotherapy and immunotherapy together. So this is a difference for N2 disease. For M1C, there's not much difference, maybe a little bit changing the prognosis, but the treatment is the same. N1C1 is multiple metastases in single organ, whereas N1C2 is multiple mets or metastases in different organ system. So this is only changes, and as I said, it may change the prognosis and the treatment options for different staging based on the AJCC 9th edition. You know, osimertinib is quite famous these days. It captured and got FDA approval already for different setting of lung cancer. We can use it with the combination of chemo or single agent for stage 4, and recently got approval for stage 3 lung cancer who can have osimertinib after chemoradiation as a curative intent. So it's a champion right now. The only setting that is left is for resectable lung cancer as a new adjuvant therapy. I believe the study is completed. Most likely we will have the updates in ASCO 2025 showed or suggest there is improvement in OS. So this is changing right now for osimertinib, and for repotrectinib, we found out it maybe has a better efficacy compared to the other agents such as crizotinib or entrectinib, and also it may have some type of activity in ROS1 resistant mutations such as G2032R mutations, and the response rate in this type of patients is almost to 60%, which is much more than the lorlatinib, entrectinib or crizotinib. So this is a difference, and we noticed 2024 was a milestone for stage 3 and 4 lung cancer with new approval. We almost had 13 FDA-approved new therapy for lung cancer, including small cell lung cancer in 2024. ADC is facing a lot of challenges these days because all those phase 3 studies was not conclusive and couldn't beat taxotere, but on the retrospective studies, there is some suggestion that non-squam histology or non-squamous histology may respond better to ADC. And also ADC may be good treatment options for the patients with targeted with actionable mutations like EGFR or ALK. ADC may have a good CNS penetration, compared to the standard of chemotherapy, and also we can use ADC if the patient has a new biomarkers. We're calling TROP2 NMR. If they have this histology biomarkers positive, the response to ADC may be much better than the average patients. So in future, we are going to see more development in ADC and lung cancer landscape treatment. So this is very important in 2025 probably. Nowadays we can make stage 3As with multiple lymph nodes or single lymph node involvement in the mediastinum as a curative disease with better prognosis. If we do the surgery on those patients, the best way to prepare them for surgery is to downstage those patients to possible stage 2 disease, and if it happens, then the prognosis would be better. So a combination of chemoimmunotherapy preoperatively can help us to make this non-resectable stage 3 lung cancer as a resectable lung cancer with the improvement of good prognosis in the future. So you need to find the right person. You need to have a good surgeon that is dedicated to do mediastinal lymphadenectomy. So it needs a multidisciplinary clinic and approach by both oncologists and the surgeon. But I'm very optimistic that most of the patients in stage 3A or stage 3B can have preoperative chemoimmunotherapy and become eligible for the surgery.